Good morning, all the dignitaries on the dais and ladies and gentlemen. Today, I have this responsibility to deliver this talk on heart failure, treatment update, difficulties,
Dear Dr.
and
Abhijita,
advantages.
can you kindly share your slide full screen?
I have full screen it is. My screen is full.
From our side, it's still not.
How
Yeah,
now?
now it is. Thank you.
Okay, all right. So this is my talk, and we start with the basic. How do we come to diagnosis of heart failure? We all know that there are standard 4 stages that have been defined clearly: A, B, C, D. A is risk of developing heart failure. B is pre-heart failure. This is very important distinction. We should have it in mind because we can prevent them from progressing to stage C. Stage C has a trajectory, and it is the most important stage of heart failure where patients have symptom, and the trajectory says that new onset or de novo heart failure, those who have resolution of symptoms with the treatment, those who have a persistent heart failure, and worsening heart failure. So because based on this, their prognosis and their treatment plan can be staged. And then, of course, the last stage, the stage D, in which patients are of NYHA class 3B and class 4. All these patients are included in stage D. So now coming to classification using the left ventricular ejection fraction. This is what we follow. Normally, we look at NT-proBNP and echocardiographic evaluation. Based on this, there is a initial classification, which is heart failure with the reduced ejection fraction, less than 40%. And then we follow with the treatment. If the ejection fraction improves with the treatment, we call it heart failure with improved ejection fraction. It's very important to define it differently. Now, we have another class where, to start with, heart failure, LVEF is 41 to 49%. So this class is different from improved heart failure from lower ejection fraction or reduced ejection fraction less than 40%. And of course, the last one, heart failure with the preserved ejection fraction, either mildly reduced, and all these stages can interchange over a period of time. So this is a very important classification for us to remember. And 4 things that are very important in symptom, that is dyspnea classification, patient at risk of heart failure, hospitalized patient for heart failure, and chronic heart failure, because based on this, we'll define the treatment of heart failure. Imaging is very important in deciding the treatment and prognosis of the heart failure patient. Apart from the chest X-ray, echocardiography, we sometimes need cardiac imaging and certain subset of patient using CMR or SPECT or CT scan sometime, and to define ischemic evaluation and other classes. So sometimes also we require invasive hemodynamics and endomyocardial biopsy tests based on the stage of heart failure. So how do we treat the heart failure with reduced ejection fraction, HFrEF, the class C and class D? To step 1 is we initiate the guideline directed medical therapy, which is now we all know that it is ARNI, beta blocker, MRA, SGLT2, and diuretics, other diuretics other than MRA. And we look at in stage 2, after the treatment, we look at them, whether they still have a persistent heart failure or not. If they have a persistent heart failure, we have to look at the other step 3. If they don't have, they have improved, then we continue on the same heart failure treatment as per the guideline directed medical therapy. These are the 5 pillars that we call nowadays. And now, if it is persistent heart failure, then how do we assess? Then there are class 3 and class 4 in certain ethnic groups. And NYHA 1 to 3 less than 3% with more than 1 year survival. We have criteria to decide 1 year survival or more than 1 year survival. And then, of course, class 1 to 3 ambulatory patient, LVF less than 35%, normal sinus rhythm, but QRS is prolonged more than 150 milliseconds with LVBP. So these are different classes. This is how we define them in step 3. And step 4, then in addition, we need to look at whether they require ICD. If they have less than 35% and survival is more than 1 year, ICD should be considered. And those who have QRS prolonged 150 milliseconds, as I said, they will require CRTD. In addition to ICD, they will require also the CRT. So, and those who remain despite this, they don't improve, symptoms improve, then we continue the same treatment. If they don't improve and they progress to stage D, then of course we require to refer them to specialists for consideration of MCS and transplant. So this is a standard foundational medical therapies that have been defined, and they are all in class of recommendation 1 and level of evidence A. So they are all in 1A class, ARNI, beta blocker, MRA, and SGLT2. Whether diabetes is there or not there, SGLT2 is considered for them. Now, what are the additional therapies that we need to look at? One is evaporatin. When do we consider? If the heart rate remains more than 70 despite optimal dose of beta blocker, then we should consider evaporatin as per the guideline. 2A. Then vericiguat. This is a new drug. It can be given in initial doses of 2.5 milligram QID and then ultimately step up to 10 milligram QID, depending on patient tolerates or not. Which patients to be considered? Those who have LVF less than 45%, they have recent hospitalization, they are on IV diuretics, and their NT-proBNP remains elevated. These are the patients we should consider for this new drug, vericiguat. Then digoxin, when do you consider? At one time, we thought digoxin may not be considered for heart failure patient, but its recommendation has come in again. Heart failure despite GDMT, that is guideline-directed medical therapy, or guideline-directed medical therapy tolerance is poor, then we should consider digoxin, but make sure that we don't exceed must titrate the dose properly, and we do not exceed the toxic level. That is more than 0, it should remain less than 0.9 nanogram per ml. This is a very important aspect of treatment with digoxin. Then new drugs that are considered is PUFA. We all know that EPA and DHA both in 1 gram dose daily are very effective in the treatment of heart failure in certain subsets of patients, and they're very helpful, NYHA class 2 and 4. And then hyperkalemia. We have a new drug that is called as potassium binder, that is patiromer. It's very, very good drug, and it is being considered for treatment in a patient where we need to use MRA, like finerenone is coming up very fast, and finerenone is now a new kid on the block of treatment of heart failure, supposed to be extremely good in patients with diabetes and reduced renal function, or CKD. So these are additional therapies that we need to look at in patient with heart failure, reduced ejection fraction. If they have less than 35 ejection fraction and they have significant coronary artery diseases, they are suitable, their anatomy is suitable for surgical revascularization, we should consider them for surgical revascularization with the viable myocardium existing. Then NYHA class 4 with reduced severe MR. If they have severe MR, then optimize the medical treatment first, and then consider if there is no age-to-age repair, that is what we call a mitral clip. And then, of course, pulmonary artery monitoring, remote monitoring of pulmonary artery pressure using CardioMEM, which is a small device permanently implanted into a distal pulmonary artery from where we can measure the pulmonary artery pressure. And then accordingly, we can adjust the treatment and monitor the patient. So question comes, when do we consider the device called CRT? We have to look at when we consider, just now we discussed some criteria that if you have EF less than 35% or less than 30%, even if they are in NYHA class 1 and 150 milliseconds QRS time prolonged in LBBB, in presence of LBBB, though they are in NYHA class, we should consider CRT-D in these patients, or CRT alone, depending on the clinical situation after assessing the clinical situation. We understand that CRT is a cardiac resynchrony therapy, and along with D means defibrillator, implanted defibrillator. So LVEF, if it is less than 35%, but these patients are ambulatory in class 4, in class 2 around, but their LBBB is more than 150 milliseconds. Non-LBBB means RBBB more than 150 milliseconds. Then LBBB, even if it is lower, but more than 120 milliseconds, lower than 150, we can consider it's class 2A recommendation as per the guideline. And even for non-LBBB, same thing. So special circumstances are atrial fibrillation. We know RV pacing sometimes is required, and these are very special circumstances to consider CRT treatment, and of course, where atrial fibrillation is troublesome. And sometimes even you need to consider for LVEF of 36 to 50% if patient has high degree or complete heart block. Those patients we need to consider for the treatment. But if they have a significant comorbidity and their survival is limited to 1 year, then we continue them on medical, on GDMT, and do not consider CRT for them. So treatment approach in mitral regurgitation, as I said, more than 50%, less than 50%, but if MR is severe with the LV end systolic dimension on echo less than or equal to 70 millimeter, and pulmonary artery systolic pressure more than 70 millimeter. No symptom, no severe symptom, we can consider them for surgery. If severe symptom, surgery is contraindicated, then mitral clip or what we call edge-to-edge repair TR. So these are then mildly reduced. Then we have already considered the treatment option for reduced ejection fraction. Now mildly reduced ejection fraction, what do we do? Here we can see that we start with diuretic, then SGLT2, ARNI, ARB, third, MRA, fourth, and then evidence-based beta blocker therapy is the last. So we have to start with mild rejection fraction. We have to start with diuretic and SGLT2. Now, adjunctive therapies, if patient has amyloidosis, cardiomyopathy, a particular type, after we make a diagnosis of, it is a type of transthyretin cardiac amyloidosis, in which we can consider wild type or variant type. Then we have to consider whether we can consider them for tafamidis, which is a new drug, It is given in 80 milligram once daily, or 61 milligram one tablet, or 20 milligram 4 tablet 80 milligram. So depending on the clinical situation and weight of the patient, we have to decide the dose, whether 61 or 80 milligram. And if they have atrial fibrillation with a risk of developing stroke because of the CHAD score is very high, more than 2, then we should consider anticoagulant therapy for this patient. And of course, if they have reduced ejection fraction, then we have to individualize their therapy. So these are new treatment which is with the tafamidis in a patient who's got heart failure due to amyloid cardiomyopathy. So if a patient progresses to advanced heart failure, for that matter, then there's a typical abbreviation, I need help, which includes 10 things. Intravenous inotrop. They are in usually class 3B and 4, as I said, of NYHA. There is an end organ dysfunction, that is CKD, or patient has a little semi-comatose condition, EF less than 35%. They require repeated shocks, recurrent hospitalization more than one time, and other things that are there which requires prognostic assessment or intolerance to GDMT. Salt, we know nowadays, whether we restrict or not restrict, it doesn't make difference. There is RCT done. So salt is something which we always thought should be restricted in heart failure. It's now not a thing which is to be considered anymore. Now, assessment of patient with hospitalized patient, why they have developed heart failure. So obviously there are some precipitating causes like acute coronary syndrome, uncontrolled hypertension. These 10 causes we all know regularly in our practice. And these causes are very important. We need to look at what is the cause and treat that cause. Then only the heart failure will come under control with GDMT. Now, decongestive therapy, of course, we need to consider loop diuretic here. Even when renal functions are going up, we have to consider loop diuretic. And of course, we have to add MRA. And these days, finerenone is supposed to be extremely good, giving long-term good result. So finerenone is a new kid on, as I said, in the heart failure. It has, after the 2 studies which are done, the Fidelity trial and other trial, Farxigo. So all those trials have suggested that this is a very good drug. Now, GDMT during hospitalization should be continued. It's very important because it prolongs the life, and very importantly, it reduces the hospitalization rate or readmission rate. So it is very important that we continue even in advanced heart failure GDMT, those who are hospitalized. So then follow-up becomes very mandatory for all these patients. Important is follow-up, because unless they adhere to the treatment, they are not benefited. And for that, follow-up is very necessary. First follow-up should come in 7 days. Then if they have under end organ damage, we should consider involving other specialists in the management of heart failure. Then GDMT, whether they are properly taking care of GDMT, adjusting the dose of diuretic, coordination of safety laboratory checks, all these things. And of course, the new thing that has come up very well, and it is should be there on the blog, that is social determinant of health. Social determinant of health means lifestyle, how much you are eating, how much you are sleeping, what are the physical activity. You must look at these and address them whenever we see the patient on follow-up. So additional therapies which we require for comorbidity management in heart failure, if BP is high, improve the BP treatment. Additional drugs can be considered safely. If diabetes is not controlled, we should consider adding higher dose of SGLT2. Then surgical revascularization if there is a lot of ischemia, related to coronary artery disease, they should undergo surgery. Multidisciplinary treatment, that is, if they have other system involvement, cancer or any other therapy, should be involved in the management of the therapy. Other specialists should be involved. Anticoagulation for all patients with heart failure is necessary because it prevents stroke. And nowadays, NOAC is very important drug for that matter. If you have iron deficiency, of course, IV iron is available for all patients, though it is expensive, but we have to consider IV iron to correction of anemia. Atrial fibrillation, sometimes we have to consider heart rate is not controlled with a standard medical therapy. Then we have to consider AV nodal ablation or CRT implantation in atrial fibrillation. And then attribute, if there is still a problem, if we can consider atrial fibrillation ablation therapy. We know that pulmonary vein, if they have evidence on the EP, that there could be a focus for atrial fibrillation from there, and sometimes ablating pulmonary vein can help in reducing atrial fibrillation related issues. Patients with heart failure or sleep apnea, we should consider CPAP therapy, and of course adjust the dose of patients with less than 50% cardiomyopathy, ARB, ACE inhibitor, and beta blocker. So, as I said, management of iron anemia with iron deficiency, hypertension, diabetes, and sleep disorder with CPAP. And sometimes not all patients requires early. Those who are in a stage 1, we can still consider in them ACE inhibitor or ARB alone. And then chronic heart failure, of course, they will require ARNI, no doubt about that. And ARNI with MRA to be considered in patient if the heart failure is not coming under control. And then optimizing beta blocker therapy becomes very important. And chronic heart failure, we need to consider all GDMT related therapy in a proper way. So apart from this, there are recommendations and disparity of vulnerable population. Those who have cardiomyopathies or some social issues or cardiovascular disease, they should be considered for this approach. Then performance. Is the concern institution looking at clinical practice guideline, and they practice that on treatment of heart failure or not, improving the quality of the life or not, and they are the performance measures where we should look at those aspects before we decide about the. And the goals of therapy, as I said, that remains the quality of life is the main thing, and of course following up them and whether they are added to treatment or not, and then of course social determinants of heart failure. So as we say that the treatment of heart failure depends on class of symptom. NYHA, no limitation in physical activity, NYHA1. Ordinary activity results in symptoms, NYHA2. Less than ordinary activity symptoms, less NYHA3, and at rest, no activity possible, NYHA4. So we should optimize our treatment according to the stage of heart failure. Symptom, those also decides the outcome. The patient-related story also decides outcome. So then evidence gaps and future directions. There are several things. These 10 things are very important. And whether patient has myocardial injury, ejection fraction is going down, or recovering cardiomyopathies. We should have a clear definition on EF, then cost, then diagnostic consideration.
Dr. Bang, could you conclude because you have already crossed the time.
Okay, sure, no problem. I'm at the last slide. The guideline therapy, we know reduced ejection fraction ARNI is important. But those who have mildly reduced ejection fraction and normal ejection fraction, SGLT2 is now a way to go. And if they are not controlled, then we can add other drugs. Improved LVEF in patient with those who had reduced EF, as I said, they need to continue on the GDMT based on reduced EF. Then only they will remain under control. The value statement created by select recommendations were of high quality, cost effectiveness of the intervention have been decided. The amyloid is there, we need to give tafamidis in a required doses, and EF more than 40%. As I said, the evidence is in favor of HLT2 if there is a diastolic dysfunction, particularly. Then patients with advanced heart failure, we should refer to the specialist for consideration MCS, that is LVAD or transplant. Then, of course, class 1 and class 2 stages, pre-heart failure, failure, or risk of heart failure, all those should be. So recommendations are provided for select patient with heart failure in iron deficiency, correction of precipitating causes. So ERNI has found to be very good for better prognosis, prolonged use of ERNI. ERNI can be used in a patient with end-stage renal disease also. And further dose escalation of medical therapy may be beneficial in this patient with improved ejection fraction also. So there is improvement in the optimization of GGMT in patient with advanced heart failure after 2021 ESC guidelines. Thank you very much for your kind attention.